Yeah. Thank you. Good morning. It's good to be here in Savannah. I'm really thrilled. And you guys must be stiff from sitting. Why doesn't everybody just stand up for a second and stretch, and then I'll get talking, or I'll start talking while you're standing up. So, you know, first of all, I was thrilled to hear, I'm from the U.S. Agency for Healthcare Research and Quality. A lot of people here might not know much about our agency, but the Project Share training that you did yesterday was developed by our agency, so I was glad about that. So I thought I'm going to break my talk into 3 sections. First, I'm going to give, I think some people here don't know much about AHRQ or what it is, so I'm going to give some background on the agency. Then I'm going to give some examples of the kind of research we support that helps provide the evidence for what works in improving care, as well as works to increase the uptake of evidence in practice. And then to make it a little practical, I'm just going to share some examples of tools and resources we have that are available for you to use to improve care locally. So what's AHRQ's mission? AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work with the Department of Health and Human Services and other partners to make sure that evidence is understood and used. And it's a small agency, and people wonder, you know, what is AHRQ in relation to kind of to the big boys, NIH, CDC, and CMS. And we have a really distinct role. So NIH does the clinical research to find out new treatments, what works. CDC works at the population level, trying to develop community interventions that improve public health. We've heard a lot about CMS and Medicare that pays the bills and sets payment policy, and is working very hard now to try to develop some innovations in the system. And AHRQ is tasked to do research. So it is a research agency to help healthcare systems deliver safe and effective treatments. We were created in 1989, initially as the Agency for Healthcare Policy and Research. And at that time we had a dual mission of supporting research and implementation of findings that continues to today. We were reauthorized in 1999, and at that time we were renamed as AHRQ, and 2 new centers were created, the Center for Primary Care Research and the Center for Patient Safety. And both of those have been a big focus of the agency since then. I direct one of the 4 centers within the agency. It's called the Center for Evidence and Practice Improvement. And our center is tasked to generate new knowledge, synthesize evidence, translate science on what works in health and healthcare delivery, and catalyze practice improvement across healthcare settings. So it's a lofty agenda. We do that, we have 5 divisions plus the National Center for Excellence in Primary Care Research. It was mentioned in my introduction, so I won't repeat them. So the Affordable Care Act created 3 broad aims that were synthesized within the National Quality Strategy. One is to develop better care, which is to improve the overall quality by making healthcare more patient-centered, reliable, accessible, and safe. The other is to really focus on healthy people and healthy communities, to improve the health of the US population by supporting proven interventions to address behavioral, social, environmental determinants of health, in the addition to delivering higher quality health care. And thirdly is to make care more affordable, to reduce the cost of quality health care for individuals, families, employers, and the government. So I think Dr. Lin gave us a good overview of what's not working. So I think now we need to start looking forward as how do we get to where we want to be? How do we achieve these, you know, really admirable goals? At the same time, HHS in the last couple of years put out their delivery system reform initiative. The goals of this are very much aligned with the National Quality Strategy. And really, it's pretty simple what we want to achieve: better care, smarter spending, and healthier people. And how do we get there? One is we need to improve the way providers are paid. And we know that sometimes the current payment systems are really a barrier to innovation. So to promote value-based payment systems and bring proven alternative payment models to scale. Improve and innovate care delivery, encourage integration, coordination of clinical and support services, improve population health, and promote patient engagement. I think we won't do this without actually hearing the voices of our patients and what do they need in our systems, meeting their needs, actually helping them attain their goals. The other is to share information with providers, consumers, and others to support better decisions and maintain privacy, and really create transparency on both the cost and quality information around the system, and to bring electronic health information at the point of care. And all of these are enormous challenges. So what does AHRQ do about all of this? There's three major areas that AHRQ focuses on to achieve these goals. We invest in research and evidence to understand how to make healthcare safer and improve quality. So the same way we need evidence about what works to treat diabetes or cancer, we need evidence about what works to improve the system. We create materials to teach and train healthcare systems and professionals to catalyze improvements in care. And I will be sharing some of those tools with you so you can access them. And we also generate data and measures used to track and improve performance and evaluate progress in the US health system. I think, it was kind of bleak listening to Dr. Lynn, even though she has great ideas for where we need to head. But, I think the good news is that we've started to demonstrate that we could actually improve healthcare when we have a will, when we're all aligned and we're all working to similar goals. And an example of this is improvements in patient safety that have happened across the nation. This is data over 4 years from 2010 to 2014. And these HACs are hospital-acquired conditions, things like hospital-acquired infections, adverse drug events, other kinds of complications in the hospital. And AHRQ really worked to develop both measures of how do we count how many of these adverse events are happening, as well as tools for how to reduce infections, et cetera. And in partnership, we handed these over to CMS with the Partnership for Patients, and it really, at scale, implemented this in hospitals across the nation. And the result was a 17% reduction in hospital-acquired infections across over 4 years. And when you look at the impact of that, it's 87,000 lives saved, 2.1 million patient harms avoided, and $19.6 billion in savings to the health system. So we can improve care and reduce costs, and now we need to do that in the community and for older people and for more complex patients. Another example of work that AHRQ has done is something called Project ECHO. I think some people here are familiar with the ECHO model. Is there anybody using that here in Georgia? So this is, often what AHRQ does is, kind of support the initial research to develop, test, evaluate models that work, and then those are either scaled by our other federal partners or even the private sector or in nonprofits, kind of make them grow. And I think one of our success stories from our health information technology portfolio is Project ECHO. And what it does is it really provides doctors in small communities access to specialists in terms of managing different conditions. It was first developed around hepatitis C in New Mexico, and what they found was, and basically there were group discussions with specialists and support for how do you manage these patients. And this intervention resulted in outcomes in small primary care practices for hepatitis C that were equivalent to the best specialty centers. And this model, actually on Wednesday, there was a rural health conference at the White House organized by the Rural Health Council. And this was one of the projects that was discussed as a model. And they've now expanded from that one condition, hepatitis C, to use this model for over 40 conditions. It's used by 80 medical centers across the country and also in 12 other countries. So it just shows how you can develop evidence. So test your models, prove them, and then people can expand them and adapt them to their local settings. So how does it, one of the things we do to generate evidence is use the evidence cycle. So we know, one study, we hear the news every day, there's this finding and then the opposite findings. So you don't really know what works till there's a body of evidence. And one of the things we do through our evidence-based practice centers is systematic reviews that synthesize the evidence. That evidence is taken up by professional societies, guideline developers, to develop guidelines, and then we need tools and ways to implement those in practice. And then we evaluate, has it worked? Have we actually improved care, improved outcomes? And then the cycle goes, repeats itself. So we know that every system is perfectly designed to get the results it gets. And we know our system was designed over taking care of single diseases and not designed around people who are more complex, who have multiple conditions and who have, social contexts that they live in that impacts their care. And we need to move in terms of transforming the health system into one that is patient-centered and meets the needs of people and their goals and addresses their social circumstances. So I just wanted to share some of the statistics, national statistics around multiple chronic conditions, because it's something that most people have or will have. 26% of Americans have multiple chronic conditions. 68% of Medicare beneficiaries have multiple chronic conditions. And 67% of Medicaid beneficiaries who have disabilities have 3 or more chronic conditions. And in terms of its impact on outcomes, we know that as the number of conditions increase, so does mortality, poor functional status, number of hospitalizations, number of readmissions, and adverse drug events. And 66% of US healthcare costs are related to individuals with multiple chronic conditions. And for Medicare, 93% of Medicare expenditures are for people with multiple chronic conditions. So you can really see the mismatch between the way we deliver care and the way the needs of the population. Just to highlight the impact of multiple chronic condition, the first bar basically shows the percent of people with multiple conditions, and then the percent on the other side is the percent of readmissions. So the top blue bar, I guess it's not a pointer, but the top blue bar shows that the 14% of people in Medicare with hospitalizations who have 6 or more chronic conditions are responsible for 70% of all readmissions. And then if you look at the 32% who have no or one chronic condition, they're responsible for a very, very small percent, less than 10% of readmissions. So if we're going to, improve care, reduce readmissions, we have to meet the needs of these people. And I've actually done some of my research where we've looked at the reasons for readmissions. So if somebody's admitted for heart failure, we do a lot to improve their heart failure care, their transitions, but why are they coming back to the hospital? Because they fall and break their hip, or their diabetes gets out of control. So we really need to develop, patient-centered models of care and care plans that address the whole person to prevent readmissions. And this shows the cost implications of having multiple chronic conditions. And here again, the 14% of people who have 6 or more chronic conditions are responsible for a lion's share of the costs. And it's pretty clear. This slide, I'm sure you can't read it from where you are, but the blue bar at the end shows the percentage of people who have 5 or more chronic conditions. And if you look at the list, these are common conditions in Medicare: depression, cancer, arthritis, high blood pressure, Alzheimer's disease, high cholesterol. You can go down the list, heart failure, COPD. So when we're talking about managing chronic conditions, we can't do that without doing a patient-centered model that addresses all of their multiple conditions. AHRQ has invested a good deal of money in its multiple chronic conditions portfolio and has developed good lessons on how to manage care. A lot of that research is on our website. And going forward, this is a huge priority for both my center and the agency. And as a matter of fact, we're starting with trying to sponsor research to figure out how do you collect the information and share it so that you could develop meaningful care plans. So how do you get into the electronic medical record information on how people are functioning? You know, are they in pain? Can they walk? Are they short of breath? What is their neighborhood like? What are their goals and values? So keep your eyes posted, because we're going to be soliciting for research in that area, because the first step to be able to make and share care plans is to have that information readily available. And as Dr. Lin pointed out, it's not there right now. So that's kind of basically AHRQ and what we do and where our focus is. And now I'm going to give you two examples of research that we're sponsoring that shows how research can really be used to both improve care at healthcare and at the same time develop evidence about what works to improve care. So I think one of our new exciting projects, it's about a year old, is called Evidence Now, Advancing Heart Health in Primary Care. And what Evidence Now is about is ensuring that primary care practices have the latest evidence on cardiovascular health and that they use it to help patients live healthier and longer lives. And I know this is a big issue here in Georgia, you know, where there's a high rate of cardiovascular disease. And the idea is to implement, you know, patient-centered outcomes research or evidence-based findings in primary care practices to improve healthcare quality. And on my next slide, I'll show you what we're focusing on. But at the same time, we're building primary care practices capacity to receive and incorporate other findings in the future. So if you learn how to do this, are you in a position where you could also improve other things? And also at the same time answering a research question. Does externally provided quality improvement support or practice facilitation accelerate the dissemination and implementation of evidence-based findings? So what is Evidence Now? We've funded 7 regional cooperatives across the country, serving 12 states in both metropolitan and rural settings. And the co-ops engage 200 to 300 small and medium-sized primary care practices each. So this is another important part of this work, is that we know there's great, you know, the US does have some of the best healthcare in the world, but it's in pockets, and the innovation isn't spread across the system. So our idea is to get out to small and medium-sized practices and allow them to improve so they could also provide the best standard of care. We've included, you know, federally qualified health centers, community health centers, as well as small primary care practices. And also the sites themselves serve many disadvantaged, underserved populations. And so we're focusing, it's linked to the Million Hearts campaign, whose idea is to, you know, reduce and prevent 1 million cardiovascular events in the US. And there's 4 focuses: use of aspirin in people who are high risk, blood pressure control, cholesterol management, and smoking cessation. This is a map. Unfortunately, Georgia doesn't have a collaborative, but keep your eyes posted for future opportunities. And but North Carolina and Virginia do have regional cooperatives. So our reach is over 1,500 small to medium-sized primary care practices, 5,000 primary care professionals, and 8 million patients. Think about if we did something like this for people who are for complex or for multiple chronic conditions. So I think this model has a lot of potential for the future. Quality improvement services. So this is kind of the approach that the cooperatives are taking, having electronic health record support, creating shared learning collaboration. So there's learning both within each collaborative but across all the collaboratives, so people could solve problems together and figure out what works as they encounter barriers. Expert consultation is available. Data, giving feedback, how are you doing, are you getting better? And really on-site practice facilitation and coaching. And for those of you who don't know what practice facilitation are, they're specially trained individuals who work with primary care practices to make meaningful changes designed to improve patients' outcomes. They help physicians And improvement teams develop the skills they need to adapt clinical evidence to the specific circumstance of their practice environment. And so it's recognizing that every practice is different, every community is different, but that if you build the capacity for improvement, people will be able to continue doing this in the future. And we're going to be evaluating it. We're going to be evaluating whether care is, actually improved. And we also have a national evaluation center so that we could learn across all the sites what works. But we're also measuring practice capacity. Have we improved practice's ability to actually do quality improvement? And also we're using mixed methods of evaluation, so we're measuring the numbers, but we're also going out there to get the context about what works, why it works, and in what kind of settings. So that's one model of interventions and research that we sponsor. I saw Congressman Carter talk this morning, and everybody knows that the opioid epidemic is tragic. The line just shows the number of hospitalizations, and how they continue to rise. It's really tragic circumstances. But we're actually sponsoring, we had a call for proposals. We're actually reviewing the applications next month, and we'll be funding a series of research to help, and this is focused on rural practice, to help rural practices develop the capacity to do something called medication-assisted therapy, which uses evidence-based medications in conjunction with, counseling and behavioral supports to improve, and help treat people who have opioid addiction. And there's many barriers because many primary care physicians haven't been trained in this area. So there's limited training available. There's often negative perceptions about people with substance abuse disorders, and especially in rural communities, there's often lack of social support services and the counseling and the resources needed to do this. So how can we improve care to these communities? So we're going to be funding a series of grants, 3 research demonstration projects to support implementation of MAT for opioid abuse in rural primary care areas and practices, and projects will explore and test solutions aimed at overcoming the barriers I mentioned. And some of the solutions include online training, use of telehealth, in-office practice coaching, virtual counseling sessions for patients. So we're very excited about these upcoming grants and help. There's a lot of work. I know there's big investments in dealing with the opioid crisis, but we really need the science of how do you actually do this in practice and what works, and I think these grants will have great potential. So I'm going to stop there and move on to some of the tools and training materials that we have, because I think some of these may be useful for you. So we have patient safety culture surveys. People might be familiar with Team Steps, which has been available for over a decade, that helps teams work together. It was designed for the acute care setting, and I'll talk a little bit about that, a little more about that, because last month we released Team Steps for ambulatory care. So there's tools available to improve the functioning of teams and the work of teams in community and ambulatory practices. I've talked a little bit about the tools for reducing hospital-acquired infections. We have tools for re-engineered discharge tools to reduce avoidable hospitalizations. We have a guide to patient and family engagement. And 2 of the tools that in my center I think are particularly useful are the NGC, or the National Guideline Clearinghouse, and the National Quality Measures Clearinghouse. And these are online, and they're really an incredible resource to get guidelines for different conditions, to be able to compare guidelines, and as well as quality and measures. So those are available and a really valuable resource. And then we also have quite a number of tools for practice improvement. So I talked about Team Steps. So in order to deliver accessible, coordinating, comprehensive, patient-centered care, we need a team. I think everybody here knows that. I've heard a lot of discussion about teams. So we released team steps for ambulatory care. Here's his team steps for primary care practices. And there's a whole host of resources and tools to make it easy for teams to strengthen themselves and work together. And they're adapted to multiple ambulatory care settings, including primary care office, specialty office, pediatrics, small rural offices. So, I encourage you to, if that's something that's useful for you in your work, to kind of access and use those tools. We also have a host of tools, a really wealth of tools for primary care transformation. And we have the Primary Care Medical Resource Center website, the Primary Care Measures databases if you want quality measures for primary care, and we have improving primary care practice information also for health professionals. So this is just the website for the Primary Care Medical Home Resource Center. There's lots and lots of information available there. We have a whole portfolio of tools for how to do practice facilitation, how-to guide, primary care practice curriculum handbook, and we have a whole series of primary care quality improvement products. The other thing we do is we release information like summaries to help people manage different conditions based on the results of our systematic reviews, and then we package that information both for patients and providers. And one of the most recently released tools is how to treat alcohol use disorder, and new research summaries to help primary care clinicians and patients make evidence-based decisions about treatments for alcohol use disorders. And we know here's an area where there's a big gap in practice. We know alcohol use disorders are very prevalent. We know they're under-recognized, under-treated, and we know that a lot of evidence-based treatments are not being used. There's more than 68 million adults in the US who have some kind of alcohol use disorder, and fewer than 10% of them receive any kind of medication or for their treatment. And so the research summary is based on review of over 135 studies conducted by AHRQ's evidence-based practice centers. And then just briefly, I'm a health services researcher. I work with big databases. I'm a data nerd. But some of the data products we have here are very useful that you should know about. This is the last bucket of work that AHRQ does, is develop measures and data. So we have the consumer assessment of healthcare providers and systems, CAPS, which helps assess patient experiences with care, the medical expenditure panel survey, which really gives us a window on how the health system is performing across the US. Then we have the Healthcare Cost and Utilization Project that has a very useful resource that I'm going to mention next that I think is useful for this group. We develop quality indicators and also the National Quality and Disparities Reports, which reports both nationally and at the state level. So you could go to the quality report and see how Georgia is performing on a whole host of quality indicators, as well as looking at what are the disparities in the state. So this is a really nice tool. It's called HCUP Fast Stats Online, and this is basically made by using hospital discharge data, there's emergency room data, there's ambulatory surgery data. So this new web tool, anybody could go online and use it, allows users to analyze the latest state-by-state info on hospital discharges. It includes all payer data on discharges from 2014 from 17 states. And there's the data on the number of discharges paid by Medicare, Medicaid, private insurance for surgical, mental health, maternal injury, and medical categories. And so you can use this to see how you're performing in a particular state. So for examples of relevance is Colorado was a Medicaid expansion state, increased Medicaid covered hospital stays by 50%, and decreased uninsured hospital stays by 90%. And then Missouri, that did not expand Medicaid, so no change in either category. So you could start looking at using these stats to see how different adoptions of policies actually impacts upon care at the population level. So I'm just going to finish here. I hope there's some time for some questions. I'd be happy if there's a few minutes to answer questions from people. But, you know, going back to the three aims, you know, for the National Quality Strategy, you know, better care, healthy people, healthy communities, affordable care. It's not going to happen unless everybody in this room is engaged. I mean, this has to happen at the local level. So I'm really, you know, again, pleased to be here and, you know, be able to, I'm looking forward to listening more and learning what's going on here and from the presenters later. But I just realized that, you know, before I end, I have to make my disclaimer. I'm a federal employee, but whatever I say represents my personal views and not that of the US government. So, thank you.